Hello, my name is Usama Naga. We'll discuss in this section the floppy infant and the evaluation of hypotonia in infants. This presentation is a supplement to the neurology chapter in the pediatric board study guide. My objectives in this presentation to be able to characterize the distinguishing features of hypotonia and muscle weakness, describe the differences between central and peripheral causes of hypotonia, generate a differential diagnosis of hypotonia in infants, discuss the appropriate medical and genetic evaluation of hypotonia in infants, understand the need to suspect infant botulism in an infant younger than 6 months of age who has signs and symptoms such as constipation, listlessness, poor feeding, weak cry, a decreased gag reflex, and hypotonia. I prepared this presentation based on an article published in 2009 in Pediatrics in Review. The first and most important question to ask when we have an infant with hypotonia or a floppy infant, is it central or peripheral? Close to central causes of hypotonia: depressed level of consciousness, dysmorphic features which is commonly associated with syndromes, fail to imitate facial gestures, predominantly axial weakness, abnormal development or delayed milestones. When you do physical exam, the reflexes here in central causes will be hyperactive or normal reflexes. Close to peripheral causes, the infant is usually alert, not depressed, usually normal organs. Poor feeding, the weakness may involve the respiratory muscles, and you will see the infant mainly using the abdominal muscles to breathe. And the weakness is more distal, not axial. And the weakness is profound weakness. So infant with peripheral cause, they are much weaker than infant with central causes. And when you do the physical exam, you will see the reflexes here are depressed or absent. And if you look at the tongue, which is the best place to look for fasciculations, which is a spontaneous contraction of muscles, you will see the fasciculation in cases with lower motor neuron lesions or peripheral causes. Suggestive signs of central causes of hypotonia in newborns: early seizures, abnormal eye movements, apnea, exaggerated irregular breathing patterns. In infants, fisting of the hands beyond the first few months of life is abnormal. Scissoring on a vertical suspension, hyperreflexia. The most common cause of central hypotonia is hypoxic ischemic encephalopathy. Causes of hypotonia and weakness in general: central, which is the brain and the spinal cord, then peripheral, starting from the anterior horn cells, peripheral nerves, and the junction between the muscle and nerve, then the muscle. So brain and the spinal cord, anterior horn cells, the peripheral nerves, then the junction between the muscle and nerve or neuromuscular junction and the muscle itself. Central causes of hypotonia: the most common is hypoxic ischemic encephalopathy, brain insult, intracranial hemorrhage, for example, intraventricular hemorrhage like in cases of extreme prematurity. Chromosomal disorders, for example, Down syndrome. The most common presentation of trisomy 21 is hypotonia. Inborn errors of metabolism, neurometabolic diseases, for example, Zellweger syndrome or Lewis syndrome or paroxysmal disorders. Peripheral causes of hypotonia with destruction of anterior horn cells. The most important cause we need to learn in this presentation is acute infantile spinal muscular atrophy. Remember, fasciculations is a common association with this illness. Neuromuscular junction causes of hypotonia: transient acquired neonatal myasthenia, which is a neonate born to a mother with myasthenia gravis. Congenital myasthenia, infantile botulism. Muscular causes of hypotonia: congenital muscular dystrophy, congenital myotonic dystrophy. Charcot-Marie Tooth disease, even the presentation in the second decade of life, but it is very important to know about this disease because it is the most common inherited neuromuscular disease in pediatrics, and very important to be able to differentiate this disease from muscular dystrophy, for example, Duchenne muscular dystrophy. The most important step in making the diagnosis of hypotonia is detailed history and careful physical examination. Family history is critical. Prenatal history is very important. Ask about the amount of fluid, fetal position, fetal movement. For example, weak infant not swallowing enough amount of amniotic fluid. This will result in polyhydramnios. Fetal position, for example, breech presentation can be associated with cervical injuries. Prenatal history, very important to ask about prenatal prenatal exposure to toxins or infections. Ask about APGAR score, for example, hypoxic ischemic encephalopathy associated with low APGAR score. Sepsis has to be ruled out in any infant or any newborn presenting with hypotonia. Timing of floppiness, for example, hypotonia presents after 12 or 24 hours for the neonate after birth looking normal, then 12 hours later or 24 hours later start to show hypotonia. This can be a red flag for inborn errors of metabolism. Neonatal history. Possible causes of hypotonia according to physical examination. If you have a dysmorphic features, this is a possibility of syndromic causes. If you have a floppy newborn with history of uterine dystonia and difficult delivery, inability of the mother to relax her hand with handshake, this is a high possibility or suggestive of myotonic dystrophy. Signs of weakness in cases of hypotonia. If you hold an infant in supine position, pulling the infant from the hand to sitting position, you will see there is no head control whatsoever. Even newborn infant, they are able to control the head momentarily. Absence of head control or lack of head control 100% beyond 4 months of age is abnormal. If you hold an infant with hypotonia from the abdomen using your hand, you will see that the head and the limb are hanging limply with no resistance. Even newborn infant, they are able to straighten their back. And in this case of hypotonia, you will see there is no resistance. And they will give you the unique or characteristic inverted U-letter appearance. If you look at the face, they have specific facial expressions with inverted V-shaped lip. And if you listen to their cry, they have a weak cry and they have poor suck and poor feeding. Normally in newborn infant, if you try to open the eyelid in second attempt, will be very difficult. In cases of hypotonia, it will be very easy to open the eyelid with no resistance. Also, cases of hypotonia, they have decreased spontaneous movements. And if you look at their abdomen while they are breathing, you will see they are using their abdominal muscle to breathe, and they have decreased the respiratory effort through the chest. If you suspend an infant with hypotonia vertically under their shoulder using your hand, you will feel the shoulders are slipping through, and you will see the legs, they are not in flexion and they are hanging limply. This is abnormal response to vertical suspension. Compare that to the normal infant. You will feel the shoulders are stable and you will feel the resistance above your hand, and you will, if you look at the legs, they are in flexion and continuous movement. Another important step to perform reflexes in all infants with hypotonia. Central causes, you will see the reflexes are normal or exaggerated, hyperreflexia. Peripheral causes, you will see the reflexes are weak or absent. Special cases like cases of anterior horn cells destruction, you will see fasciculations or spontaneous muscle contraction, and this is best seen in the tongue. Initial laboratory evaluation in cases of hypotonia is to rule out systemic disorders. If you have a newborn after birth laying down limply with no or little movement, it is essential to rule out sepsis. Ruling out sepsis is important in any case of acute hypotonia. Electrolytes including calcium, magnesium, urine drug screen. If hepatosplenomegaly is present and you see calcifications on head ultrasound, torch titers is important to rule out toxoplasma, rubella, cytomegalovirus, and herpes infection. Urine culture for cytomegalovirus. Cytomegalovirus also can cause microcephaly. If the hypotonia is considered to be central, it is practical to evaluate for genetic and metabolic causes. Indications for karyotype or genetic studies if you have several significant dysmorphic features, like in cases of Down syndrome. Other rare cases, you can use microarray or methylation study, like in cases of Prader-Willi and Angelman syndrome with microdeletion or deletion on long arm of chromosome 15 position 11.2. If the hypotonia is considered to be central plus complex multi-system involvement, consider inborn errors of metabolism. Order plasma amino acids and urine organic acids, like in cases of amino acidopathies and organic acidemias. Serum lactate will be abnormal, like in cases of carbohydrate metabolic diseases and mitochondrial diseases. Pyruvate level, ammonia will be significantly elevated, like in cases of urea cycle defects. Acyl carnitine profile, like in cases of fatty acid oxidation defects and some cases of organic acidemias. Very long chain fatty acids will be abnormal, like in cases of peroxisomal diseases. If the child is weak and exhibit hypotonia and the weakness is peripheral, consider muscle dystrophy or carnitine deficiency. CK will be extremely elevated in 1000 like in cases of Duchenne muscular dystrophy, acylcarnitine or carnitine level like in cases of carnitine deficiency. Further evaluation of peripheral hypotonia. Creatine kinase, as we mentioned, will be elevated in thousands like in cases of muscle dystrophy, for example, Duchenne muscular dystrophy. EMG or electromyogram, if normal, if the EMG is normal, central cause is very likely, not peripheral. DNA testing is beneficial like in cases of myotonic dystrophy and for SMA or spinal muscular atrophy. Muscle biopsy, it is invasive, but it is beneficial like in cases of myopathies and muscular dystrophies. Radiologic evaluation of floppy infants or cases of hypotonia. Brain MRI is beneficial in central causes of hypotonia or diseases associated with abnormalities in the central nervous system. Brain MRI will delineate structural malformations of the brain. I will give you some examples. Abnormal signals in the basal ganglia suggest mitochondrial abnormalities, brainstem defect like in case of Joubert syndrome, deep white matter changes like in case of Lewis syndrome or peroxisomal defect, abnormalities in the corpus callosum like in a genetic disease with cholesterol metabolism defect like in case of Smith-Leopard syndrome. Let's practice and give some few examples. Combination of enlarged heart and muscle weakness or delayed milestones because of accumulation of glycogen in the muscles, because of acid maltase deficiency or lysosomal enzyme acid alpha glucosidase deficiency. The most likely diagnosis of this illness is Pompe's disease. Combination of enlarged heart and weak muscle is Pompe's disease because of deficiency of glucosidase and accumulation of glycogen in the muscles. Another case, this is a 7-month-old with constipation, lethargy, poor feeding. 4 to 5 days later start to have progressive bulbar and skeletal muscle weakness and loss of deep tendon reflexes and eventually respiratory failure. What is the most likely diagnosis? The most likely diagnosis is infantile botulism. The key word here is constipation. Constipation can precede the illness or the motor effect of this disease by days to weeks, and the infant is usually afebrile. So constipation followed by poor feeding, poor suck, and floppiness or weakness is infantile botulism until otherwise is proved. Why infants are at higher risk than older kids? Because they have low gastric acid, immature immune system, and low normal flora, so they cannot destroy the spores of Clostridium botulinum. So remember, constipation followed by weakness, it is infantile botulism until otherwise is proved. If we do not think about infantile botulism in our differential, it may take days to weeks to reach this diagnosis, because simply you can confirm this diagnosis by isolating the botulinum toxin in stool, gastric aspirate, or vomitus. It is essential to differentiate infantile botulism from SMA, spinal muscular atrophy type 1. In this case, you will have a long history of generalized weakness in cases of SMA, typically no ophthalmoplegia. Cranial nerves will be affected in infantile botulism. Normal anal sphincter tone in cases of SMA. Very important to advise parents not to give unprepared food like honey or corn syrup to infants less than 12 months. Once you reach this diagnosis, immediately administer botulism, human botulism immunoglobulin to neutralize the circulating toxins in the body and provide supportive care like airway maintenance, nutrition, and ventilation support until the infant starts to breathe in his or her own. If you have an infant presenting with hypotonia, congenital heart defect, brachycephaly, flat fascial profile and nasal bridge, up-slanting palpebral fissures, what is the most likely diagnosis of this case? The most likely diagnosis, as you were thinking, is trisomy 21. Extra chromosome 21 almost affects all body organs. The most common initial presentation of trisomy 21 is hypotonia. So if you have any infant presenting with hypotonia after birth, keep Down syndrome or trisomy 21 in your differential. Not all the infants, they will present with the classic facial features or the classic presentation of trisomy 21. Even is rare, but is very important to keep in mind. And the hypotonia tends to improve as the infant or the child getting older. And the trisomy 21, very important to know, is the most common cause of intellectual disability. Another case, mild to profound intellectual disability, poor eye contact, autistic features or autism, macrocephaly, large ears, epicanthal folds, thickened nasal bridge, increased testicular size as the child getting older or in puberty, and mild hypotonia during infancy. What is the most likely cause of these symptoms? The most likely diagnosis is Fragile X syndrome. They can present with mild hypotonia during infancy. Confirm the diagnosis with the genetic testing and specifying to the genetist what you are looking for. Indications to order genetic testing for Fragile X syndrome in cases of autism: if they have dysmorphic features, mental retardation or intellectual disability, family history of undiagnosed intellectual disability or mental retardation, or positive family history of Fragile X syndrome. But not all children with autism, you have to order Fragile X syndrome genetic testing. If you have an infant presenting with profound hypotonia, feeding problems, failure to thrive, as they grow their muscle tone improve and they start to have hyperphagia, looking for food everywhere, they steal food, they become obese, they have small hands and feet, short stitures, intellectual disability, strabismus, and hypogonadism. What is the most likely cause of these symptoms? The most likely diagnosis is Prader-Willi syndrome. Confirm the diagnosis with methylation analysis, FISH study, or microarray. This will show deletion of the long arm of chromosome 15 at 1113. Another case, if you have a case with hypotonia, feeding problems, postnatal growth delay, long palpebral fissures with eversion of the lateral lower lids, blue sclera, large ears, cleft palate, skeletal abnormalities, cardiac and renal defects, mild to moderate intellectual disability. What is the most likely underlying condition? This is a case of Kabuki syndrome. It is hard to recognize this syndrome at birth in absence of major birth defects, but the usual presentation after birth is hypotonia and poor feeding. If you have a newborn or infant presenting with generalized distribution of weakness, tongue fasciculations, arthrogryposis at birth, weakness progresses rapidly to respiratory insufficiency and eventually death, what is the most likely underlying condition of this illness? This is a classic presentation of spinal muscular atrophy type 1, or also is well known as Werning-Hoffmann disease. This disease is because of destruction of anterior horn cells and it is autosomal recessive. If you have a newborn infant presenting with generalized weakness, ptosis, difficulty with feeding, requiring assisted ventilation at birth, and history of arthrogryposis, if you give hydrophonium to this infant, the ptosis will be corrected. What is the most likely diagnosis? The most likely diagnosis is myasthenia syndrome. This disease is autosomal recessive, is very rare, but also can be transient because of transmission of maternal antibodies to the fetus. The diagnosis will be established by giving hydrophonium intravenous or subcutaneous, and the only function that you can test reliably is the oculomotor paresis and ptosis. If you have a case of delayed developmental milestones, generalized symmetrical flaccidity and muscle weakness, improvement of muscle tone as a child getting older, hypermobile joints, muscle stretch reflexes are normal or only slightly exaggerated, normal lapse, and learning disability, what is the most likely underlying condition? It is benign congenital hypotonia. It is a diagnosis of exclusion. This is another interesting case. This is a boy start to walk late at 18 months and at 4 years of age start to show problem with gait, waddling gait, wide-based gait, hyperlordosis of the lumbar spine, tiptoe walking, and not easy for this child to stand from sitting using a specific maneuver. You order CK and the CK or CPK came back severely elevated in thousands. This is a classic presentation of muscular dystrophy. CPK or creatine phosphokinase will be extremely elevated in thousands. Also can be associated with elevation of transaminases, AST and ALT, and can be misleading for liver disease if you do not check CPK. Whenever we mention muscle dystrophy, we have to differentiate that from another condition. Even the presentation is late, but I find it very important to differentiate that from muscle dystrophy. Both of them, they share weakness. Both of them, they have weak muscles. and they present with weakness. Tiptoe walking is a red flag for both conditions. So tiptoe walking may be the initial presentation in Duchenne muscular dystrophy. So any a child presenting with tiptoe walking beyond 2 years of age, you have to examine the child carefully and rule out cerebral palsy, Duchenne muscular dystrophy, and other conditions. The weakness in Duchenne or muscle dystrophy is proximal. In this condition is distal. The presentation of Duchenne muscle dystrophy, the classic, is 4 years of age, around 4 years of age. Here in the second decade of life, if you order CK for Duchenne, as we mentioned, will be elevated in 1000. Here will be normal. If you look at Duchenne, they have bulky calf muscles here. They have wasted muscles in the leg and also the hands. The genetic inheritance here is X-linked. Here is autosomal dominant. This is the most common inherited neuromuscular disease. It affects boys and girls. It is autosomal dominant. It's because of abnormality in myelination of peripheral nerves. They will present with wasting of the muscles in the legs. Also will affect the muscles of the hand, but usually they start with the legs. Pes cavus, tiptoe walking, weakness, diminished reflexes. Here affects only boys. The problem here with the muscles because of mutation in dystrophin gene and degeneration of muscles. Remember, CK will be elevated. If you do not order CK for this illness for Duchenne, you will miss this diagnosis if you do not think about it or order it. Two conditions here I would like to mention before we end this presentation. They are common, very important not to miss. If you have a newborn with hypotonia and persistent jaundice or unexplained jaundice. If you have 9 months old who is exclusively breastfed and presenting with hypotonia. What to do next in these two conditions? Hypothyroidism can present in neonates with hypotonia and persistent jaundice. If TSH level is very elevated, this will confirm the diagnosis. Vitamin D deficiency can present in infants who are breastfed exclusively without vitamin D supplementation, and the presentation can be hypotonia as well. If you order hydroxy vitamin D level, if it is low or very low, this will confirm the diagnosis. This is an excellent table explaining methods of diagnosis of cases of hypotonia and the percentage of successfully diagnosed cases. As you see here, history and physical examination is responsible for 50% of the cases. This is step number 1. This is the most important step, including family history, prenatal, perinatal, neonatal, complete neurological examination. Imaging studies including CT and MRI responsible for 13% of the cases, clinical genetic evaluation 9%, genetic testing 6%. In order to have a successful genetic testing, you have to specify the dysmorphic features and what you are looking for in the genetic test. This will yield 6%. Biochemical evaluation 6%, neuromuscular testing 6%, follow-up testing is 7%. General treatment of all cases of hypotonia directed to the underlying cause. Regardless of the diagnosis, physical and occupational therapy should not be delayed for the final diagnosis. Nutritional support also should not be delayed. For example, inserting a big tube to provide appropriate calories, genetic counseling, and social support. In summary, causes of hypotonia can be classified to central, peripheral, neuromuscular, and muscular. If you have a history of birth depression, seizure, hypoxic ischemic encephalopathy, this indicates central cause of hypotonia. Dysmorphic features suggestive of syndromic cause of hypotonia, feasting beyond the first few months of life, and scissoring in vertical suspension, they are suggestive of central cause of hypotonia as well. If you have weakness and normal cognition, the most likely underlying cause of hypotonia is peripheral. Finally, on physical examination, if the tendon reflex is depressed or absent, this is an indicative of a peripheral cause of hypotonia. This is the end of this presentation. Thank you for listening. This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.